welcome. We're so happy to see everyone. These are some of our favorite events always. Today, you're joining us for our pop-up presentation. Today's presentation is titled Defining Dosage, Supporting Family Capacity. Pop-up presentations are rather new in the EI and WI world. They are just what they sound like. We hold pop-up presentations whenever PD need or opportunity shows itself. And today is just one of those opportunities. The resource team went to DEC this year, and many of us attended a session that was hosted by Melissa Sheldon, a name you all know and love, and our guest that we have with us today, Jenn James. So we're very excited by the information that she shared at DEC, and we thought our workforce would also be just as excited. So, without further ado, I will step into some little housekeeping around these pop-up presentations. The first half hour or so of today's time together will be Jenn sharing information, giving a presentation. That portion of today's meeting will be recorded and it will be shared on the Resource YouTube channel, in a couple days, probably. Um, we ask that during this first presentation portion that you keep your microphones muted, that's so that that recording is nice and crisp and everyone can hear and understand. Um, there will be a Q&A session that follows Jenn's presentation today. And during that time, please unmute. Um, we'd love to hear all of your questions. Jenn is here to help. And that portion of today's meeting will not be recorded. That's so everyone can feel free to speak freely. If you need any clarification during her presentation, we ask that you put that into the chat. But if you really have some discussion questions, then we ask that you just wait and share those during the Q&A session. Just a quick caveat before Jenn gets started today. We love Jenn's information that she's sharing. We went through it with her. As I said, we were all very excited about it at DEC. But we have to have this caveat that although we welcome our speakers wholeheartedly and we're excited, we don't necessarily agree or disagree with the information they share. All of you all know the resource team that we're really serious about vetting our information and doing research. And what we know about Jenn is that her information is spot on, and we're excited for you to hear it today. Okay, so again, we are happy and feel privileged to welcome Jenn James today with us. I'm going to hand it off to her because she said that she will just introduce herself and tell you all a little bit more about her. So, Jenn, take it away.
All right, and hopefully you guys can see my screen. So I am Jen, and like these guys said, I work very closely with Melissa Sheldon. So she is our program chair here at Wichita State. So I work full time in a physical therapy doctoral program now. But before I started working here, I was an early interventionist in Western North Carolina. So I was a physical therapist there for the team that Sheldon and Rush used as their model demonstration team. So worked really closely with both of them, which was obviously a fantastic experience. And I'm now working on a PhD looking at dosage in early intervention. So I'm going to talk to you guys a little bit about some of the research that I've done, some of the things that I've found, and then really specifically on a pilot study that I've done on a new way to talk about dosage in early intervention. And I will tell you, I have way more slides than I'm going to have time to spend time with today. I'm sharing those with you because I think there's resources on there that can be helpful. So we'll go through some of this kind of quickly. And if you have more questions about the research side, or if that's something that you have interest in and want to talk more about, please don't hesitate to reach out via email or what have you. But I'm going to focus mostly on clinical applications today because I know as an early interventionist, this was always the thing that kept me a little unsettled. Thinking about dosage and thinking about the right way to make sure that children and families are getting what they need. And I really like these two cartoons. I like to talk about this when I talk about this topic because, on one hand, as early intervention providers, we are working with parents who have a child who they may not ever have been around children at all. They may have had a lot of children before, but this child, in addition to the new experience of parenting in general, when a child has a disability, especially if that disability is more complex or if that child has a lot of medical needs, the parent can feel a little uncertain about if they're really qualified to do some of the things that we're hoping they'll do with their child. And then at the same time, we're fighting this age-old problem of what the literature calls adherence. And I'll tell you, I really dislike the term adherence because I think you guys all know as EI providers, we aren't just giving parents something to do because we're in charge and they need to do what we say. We're really coming up with that between visit plan together. But we will often find, or I often found as an EI provider, that between visit plan did not feel like it got the attention that it deserved from me or from the family. And so I want to talk about that a little bit more as we go. So have some objectives for you. And talking about how we define dosage, there's lots of different ways to do that. In PT, we talk about the FIT principle, where we talk about the frequency, intensity, time, and type of intervention provided. In early intervention, when we say dosage, we often mean how often the provider is coming and how long they're staying. That's what we would document on that IFSP. But there's lots of different ways to think about this. But something that always gives me pause when we talk about dosage is this notion that if we're going to use that word and think of what we do in that way, we would never go to a doctor who gave us a dosage of medication and hoped for the best and didn't follow up with us on whether we took it and didn't think or at least understand how much we were taking and how often. Because when we go to the doctor and they prescribe us something or they recommend something to us, they're very careful to follow up, make sure that we understand, and they need to know exactly what we're doing. And I think sometimes in early intervention, we undercut ourselves a little bit by developing these really great between visit plans and even being good about saying, oh, the between visit plans where all the magic happens. This is where the child's really going to make progress. But then sometimes when we come back on that next visit, we get in such a hurry to get to the activity setting for that day or to get to whatever's been going on that we don't spend the time to figure out what happened when I wasn't here. And it keeps us from communicating to parents how important that is. And we also ask this question about how much is really enough. And there is a ton of research that I could get into about how much is enough for children and families. We're working on motor learning. We're looking at physical health. We're looking at mental health. We're looking at the dosage that caregivers need in order to really implement things between sessions. We're looking at, what other routines the family's involved in. How many services are they receiving? Do they have services in addition to EI? Is it just EI? And all of that kind of creates this web of not being sure what do families need from us. But the statistic that really always jumps out to me is from a systematic review looking at effect sizes for early intervention treatment. And they found that to have a medium effect size, so to be, mediumly impactful, a child with a complex disability needed about 350 days of EI occurring in the 3 years that they spent in an early intervention program. Now, if you do the math, that breaks it down to about every third day. If we get that child from the time they come home from the hospital until the day they turn 3, every third day to have that medium effect size. Now, obviously, if that disability is a little less complex, that number changes a little bit. But for me, as a provider who was mostly working with kids with more complex needs, that was really jarring because sometimes, even on our days of our best intentions, when our caseload is a little bit less unmanageable, it can be hard to try to see families twice a week, which is what that generally boils down to. And sometimes we don't feel like we have the manpower for that, or the ability to figure that out from a teaming perspective. Or sometimes families don't want us to come that often. And so I think we have to reconsider how we think about dosage. And I would hate for you to kind of come away from this conversation thinking that I'm telling you that you don't have to go as often because all these great things are happening between sessions. Because I'm not saying that. And I'm going to talk to you about how important it is that we come frequently enough to help families. I also don't want you to hear me say, well, if you come often enough, what happens between sessions won't matter. What I'm really saying is we have to maximize both of these things because if we don't, families are not going to get the practice that their children need happening. So we know from a Mahoney article in 2009, that one of my touchstone articles, that 93% of opportunities for practice occur outside of sessions. This was based on EIPTs who are providing 1 hour of EI services a week. So most of the opportunities for practice happen when we're not there. And we also know from the literature that practitioners are not generally documenting or assessing what caregivers do between sessions in a formal way. So there are some things we might do. We might touch it on our between visit plan. We might do some sort of log. We might have families estimate how often they did a routine or things like that. But when we do that, we're often tracking more of just whether a routine happened or whether practice happened. And we're not really getting information on what kind of practice was this? How much was it? And we know from the literature that those things matter to how children make progress. So before I get into a little bit of the pilot study that this is pulled from, I want you to think about what assumptions you make about how much the families on your caseload practice. Do you think they practice a lot for long periods of time? Do you think they practice a lot, but they're quick practices? Do you think they practice once in a while, but for good chunks? Or what do you think those patterns look like? And while you think about that, I'm going to just briefly talk to you about a pilot project that our team at Wichita State has been working on, where we interviewed families to talk about what helped them act between sessions. And we did qualitative interviews, we did surveys, we had them estimate how much they thought they practiced. And then we did a follow-up study using a technology called ecological momentary assessment. And in this process, I'm going to call that EMA, they get a quick survey that takes less than 2 minutes to fill out every day, asking them essentially, did you practice? How long did it take? What helped make it happen? And those surveys came at the time families had identified that they were likely to practice. And so I could say a lot more about EMA, but for the purposes of today, I'm going to get right to the data. So as I said, we asked families to anticipate how much they thought that they would practice, and then we compared it to how often they recorded themselves practicing. And families estimated that they would practice about 5 times a day for about 11 to 12 minutes, and that they would get a total of 71 minutes of practice a day. And that kind of surprised me on its face. That was more times per day than I thought families would expect to practice. And when we recorded the data, we did it in 2 chunks. One where we ran all the days, regardless of whether practice happened, and one where we only looked at the days practice happened. And obviously, we had higher numbers when we only looked at the days practice happened. But overall, in this including days with no practice category, we saw that families were pretty correct on how often they were practicing. It was around 4 times a day. However, only doing about half the number of minutes they expected during each practice time, and their overall practice minutes were much lower than their anticipated number. And so the first thing that we learned from this pilot was that the parents in our study were reporting more than they were doing. And that's pretty consistent across the literature for different kinds of between session planning, whether that's from physical therapy, occupational therapy, speech language pathology. It's also consistent in psychology studies, behavioral change literature. People overreport how much they do. But it was interesting to me that families were correct that they were practicing often. The other thing we did in this study is we asked them what helped on days that practice happened. And we were able to create a model. And I'll spare you some of the statistics, but as an early interventionist, this is one of those things that makes me very happy because our top three predictors were really strong and paint a really clear picture of what helped families make practice happen. The number one predictor of minutes of practice on any given day was the family having at least 4 sessions a month compared to having two. All the families in our pilot had either 4+ or two. And the 4+ folks practiced an average of 17 and a half more minutes per day. So being in that category accounted for 17 and a half more minutes of practice per day. Um, the second two indicators were very close together. And the first one was therapy that fit into a daily routine. And the second was therapy that was fun for the child. We used that term therapy because this study we were specifically working with EI therapists, but a lot of these kids had conditions that are going to fall under that, where this could be early childhood special education very easily as well. And if that service fit into the daily routine, families practiced 11 minutes more a day. And if that intervention was fun for the child, it was around 11 minutes more a day as well. And so we had some other indicators in there that were less significant, but those three sort of led the data as far as what helped caregivers make practice happen. And so when we looked at this qualitatively, families painted this picture for us of the importance of their concern driving their intervention and the importance of the way that they integrated the services that they were getting into daily routines. Those were some of the consistent themes that we got. Integration really mattered, and concern really mattered. So when we jump into that, we see that this is true in the psychological literature. Action and concern play in with one another really strongly. And parents need to feel motivated in order to act between our sessions. And this is a very cool model that a member of our team made to talk about how these come together from a big picture psychological perspective. We know that threat appraisal, which is caregivers who receive EI, it's their understanding of how at risk is my child? How worried am I that my child's condition is serious and is something I need to be concerned about? And then they also have this coping appraisal, which is how capable am I of helping make my child make the improvements I'm hoping to see? How much is that under my control? And what this model shows is that if they had zero concern about their child, motivation and changed behaviors didn't happen. And if they felt powerless, motivation and changes in health behaviors didn't happen. The places we can impact this as providers are first by providing information that helps families understand their child's condition and understand the power of their role as caregivers. But the second is to circumvent this motivation principle entirely and provide families more prompts to shape the behaviors that they want to have. Because cues to action are a backdoor to changing health behaviors. And so in our pilot project, we looked at both. We looked at helping parents understand what they wanted to do and that it could help their child. But then we also looked at providing these prompts between sessions. And over in their qualitative interviews, families told us that both were helpful. They wanted to have the right level of concern. Too much was paralyzing, too little caused them to be apathetic. But they also needed the reminders because life gets busy. And this all plays into this idea of locus of control. And do families believe that they are the thing that makes the difference for their child? And when we think about that data that I showed you about those main predictors, part of that locus of control is parents need enough support that they build that confidence that the things they do make a difference. And sometimes that support can come from us being there in person, and sometimes it needs to come through other mechanisms. So, these are some examples of ways that different locuses of control might work. Families with a high internal locus of control, who believe they are the thing that can help their child, are going to ask you more questions. They're going to do more between sessions. They're going to answer those self-attribution questions the way that we're hoping. So when you say, wait, man, what's been helping your child learn so much? They're going to know it's me. I'm what's helping. Families with that external locus of control are going to see their provider as the hero in the story. They're going to think, aren't you supposed to be doing this for me? They're going to bristle a little bit sometimes against coaching because they want you to come in and fix this problem for them. And so part of what visit frequency allows us to do is shape families to have a more internal locus of control and to understand, yes, I'm coming more often, but I'm doing it to support you as a parent. And I'm going to place so much emphasis on what happens between our sessions that there can be no mistake that your actions are more important than mine as a provider. And so a lot of what we saw in our pilot was this concept of caregivers needing to understand the power of what they did between sessions. And when they had prompts to that, and when their interventions fit in their routines, when they were fun, when it made sense to them, they were more likely to take action. And so this is just some data from the literature about who tends to fall into that internal versus external locus of control. And you'll see here a lot of the families we see in early intervention have things that have already happened to them that are outside of their control. And so as we're coming in, we want to be very careful about this. And I have some questions here that are some examples of coaching questions to help families really implement carryover between visits. But the other thing I want to show you is if you want to scan this QR code, it leads to a document that we made. And the first page of the document has some questions for prompting reflection for families that are having trouble with adherence. So you come in, you ask about their between visit plan, and they haven't done it. They haven't looked at it. They haven't thought about it. It has some questions to lead you through considering if this family isn't acting, it's probably not because they don't want their child to make improvements or to reach their outcomes. In general, caregivers want their children to reach their outcomes. When that adherence isn't happening, it is often because caregivers see something other than their action as the solution to their concern. And so the first page of this tool takes you through some questions to reflect on what might caregivers be counting on. And then the second page of this tool is designed to walk you through some of the different kinds of prompts we can use to support parents understanding their role and accepting how important their action is in their child making progress. Lots of different kinds of prompts on there. Some of the prompts we provide actually look like having sessions more frequently. And that's that first kind of highest support level of prompts. For some families, and we saw this in the pilot really clearly, they need us to be there more often in order to make the changes that they need to in their routines and activities. Some families need a reminder from a really structured program like the one we did in our pilot. Some families need an alarm set on their phone that reminds them this routine's important to me and I want to implement something new. I have known families who I worked with one mom who she had a candy jar. And if her child helped wash dishes, everyone in the family got a piece of candy. And then at the end of the week, she could look at that candy jar and see visually how well she'd done helping her child do the dishes. And so that was a cue for her. There's lots of different ways to build prompts into our system. But if you only take away one thing, from this talk, I hope that it would be frequency really matters. And specifically, Our job is to provide the caregiver with frequent, tailored supports so that they can provide frequent practice to their child when we're not present, and kind of reframing this piece of I'm providing service to the child when I'm in the home. And then, I'm also hoping service gets provided to the child when I'm not there. And seeing ourselves as working to shift parents and caregivers from this, I need you to help me, to I can do this. I need to learn so I can be more effective. So they pull this more internal locus of control. Our frequency matters a lot. Again, it accounted for 17 and a half more minutes of practice a day in our pilot. So we need to be providing enough support. And when we're working in programs that don't have the staffing to allow us to have more frequent sessions, we need to be thinking creatively about how we can prompt and check in with families when we're not present. And I'm not saying you need to be constantly on your phone, working when you're not at work, trying to catch up with everybody. A lot of these prompts, and that tool has more specific ideas, are passive things that you can implement as a provider that will give prompts without you even needing to interact that much with it, that help families, again, be reminded of the opportunities that they have between sessions. A second takeaway, interventions should use routines. In our data and in the other literature that you read, caregivers are not practicing for 30-minute chunks of time. They're just not. They're doing 5 to 7 minute bursts during a routine. Toddlers don't have these huge long attention spans. And so the other piece that we should take away when we talk about routines is one routine is probably not enough. If caregivers are implementing a strategy during bath time, yeah, the child's going to get to practice during bath time, but not all toddlers bathe every day. And so they might not even be getting daily practice if that's the only routine we focused on. So we need to think about breadth of routines and not expecting caregivers to pull off a perfect 45-minute laundry time where the child is engaged in learning the whole time. If we set that expectation, caregivers are going to get frustrated and decide not to continue trying. Um, when they're practicing a lot. So we need to help them understand that short routines are very powerful. And that also gives us an inherent prompt. If they know they're working on putting shoes on, then every time that child puts shoes on, it prompts them to try that new thing you've been helping them with. And again, fun predicted adherence strongly in our study. So involving siblings to make things fun, involving friends, doing things that children enjoy. But routines are a very important mediator of what we're trying to do. And then the third prompt, before I let you guys kind of ask some questions, because I would love to give more details. Again, this is kind of a fast and furious overview, but this is data that we need. And I say that as a researcher, and it's really easy for me where I'm sitting now to be like, oh, yeah, we have to have this data because I have time for data in my life now. But I really want to emphasize, and I'm going to leave you with a story. This is data that helped me as a clinician. Before I was doing any kind of structured research on this, I chose to take an academic job and pursue a PhD because the data that I wanted for this was so helpful to me when I had it as a clinician that it felt significant to me to keep exploring this. The first time I really started thinking about frequency in this way was during COVID. And I was working with a family who were pretty poor adherers. Um, and they had a bunch of kids and they lived in a really rural area. And so the child's mom was not interested in video visits, just completely uninterested. And she told me that. She told me, well, what we're going to do instead is we're going to do a phone call once a week and we're going to talk about what I should be doing. And then I'm going to text you pictures and video every day. And that way you can see what we're doing, but I don't have to do a live call. And then when we do the phone call, you can review all the pictures and videos. I'm going to send them as I get them so that I'm not forgetting, and then we could just keep going that way. And so we agreed to try it. And it was incredible how much better her child started to get. And when we talked about it, a lot of what came out of that conversation is she didn't realize how many things she was trying or how much they could matter. I had been trying to get her in a higher frequency pattern with me for a while. I'd been scheduling visits with her twice a week, and she would religiously cancel the second one because she did not want me at her house twice a week. But when she started to prompt herself and document what she was doing, the whole situation changed because she started implementing things in a more strategic way. She started paying attention to the chances she had to help her son. And that was really the first time I started thinking about frequency in this way. And it was really impactful for me with a lot of families. But one of the biggest changes was my posture. Rather than coming into a session and saying, "Oh, I have to help you with this, this, and this. We have so little time. I can't come as often as I want to. I need to come more. I need to do more with your kid." It was the posture of me saying, "The most important thing I do with your family is teach you to do things between sessions. And if when I'm here, your kid has a breakdown and they can only be around for 2 or 3 minutes, but you get strategies you can use when I'm gone, that's a hugely successful visit. We can go a long way on that because as a provider, the things I'm asking you to do are the things that matter." And I think we all say that. And I certainly was saying that even before I started thinking about this in this way. But then what I would do is I would come back and I would measure everything that happened while I was there. And the IFSP would talk about the data for how often I was there and how long I was there, what I did while I was there. And I wasn't doing anything to demonstrate the importance of what happened when I wasn't. And so the shift for me was starting to take notes on how much parents said they practiced and to treat that like it was as or more important than what I did when I was there. And when my posture changed and when I started taking caregiver carryover very seriously, I found that families did too. And so, as clinicians, not even just as researchers, we are helping families make between visit plans because we know that they're important. And we want to make sure that families understand the importance we place on them. And part of that is thinking about ways to make sure it's happening and ways to treat that data really seriously. So I am happy to answer any questions that you guys might have. And again, I could talk a lot longer about this, and I have given you guys all these slides, plus I have some references. So if you want more information on this, please don't hesitate to reach out.
Yeah, thanks, Jennifer. I'm going to transition us out of this first portion of the meeting and we'll stop recording and then we will open it up for a Q&A.